बहुत
Hello, hello. I'm sorry for any inconvenience. I don't know what happened to my internet. Okay, so we are going to continue from where we left. Okay, all right. So I just recorded the 32-minute session. So you will receive two recordings today. Okay, all right. Okay, all right. So can you guys hear me properly now?
Yes, very good.
Okay, thank you. Okay, I think everybody have joined. Let's start our class now. So let's do it now. All right. So from where we left, we were doing the cardiac troponins. So I was discussing the cardiac troponins with you guys. So cardiac troponins will start to rise after 4 hours. After 4 hours, they will be seen in the blood. And the reason is that after 4 hours, you get the rupture to the myocardium. And once your myocardium get ruptured, it leads to increase in the cardiac troponin I. Okay, troponin. And troponin start to rise after 4 hours and they remain okay. So after how many hours you will see the peak of the troponins? The peaks after 24 hours. After 24 hours, you will see the peaks for 24 hours. You get the peak troponins will be there. They'll be at the peak. Okay. So they will be at the peak after 24 hours. All right. And can anybody tell me they remain elevated for how long? How long they are going
for 7 to 10 days.
they are going to remain elevated for 7 to 10 days. Okay. 7 to 10 days they remain elevated in the blood. Okay. So that's actually the fate of the troponins. But we also measure another cardiac marker that's called CKMB. CKMB. So CKMB is not specific for the cardiac muscles. It can be elevated in the skeletal muscle injury as well. But there's one importance of CKMB that I'm going to tell you why do we use the CKMB. Now CKMB's level start to rise in the blood after 6 to 12 hours of the MI. So they start rising after 6 to 12 hours. And their peak is also seen after how many hours? Their peak will be seen after 16 to 24 hours. After 16 to 24 hours, you will see the peak CKMB levels. And these CKMB remain elevated in the blood for how long? They are going to remain elevated in the blood for up to 48 hours. Up to 48 hours, they will remain elevated in the blood, but they will downtrend. You will see the downtrending of them after 40. So it means any patient who gets second MI, unfortunately, any patient who gets second MI after 2 to 3 days of the first, what cardiac biomarkers you will use to diagnose the disease, that will be CKMB because troponin will be elevated because troponin is going to go down after 7 to 10 days. After 7 to 10 days, it will get, lower. But if the patient who received reinfarction after 2 to 3 days of the first MI, the best cardiac markers which we will use is called CKMB. Okay, so this is actually the diagnosis of the MI troponins we discussed. Now there are we will discuss the leads of the EKGs. What are the leads of the EKGs? So ECG leads are there. ECG leads, EKG leads. So ECG is actually composed of 6 chest leads and the 6 limb leads. So these EKG leads will tell us the what portion of the heart is getting MI, or what part of the artery is getting blocked, or which artery is actually blocked. These EKG leads are going to tell us. Okay, so EKG leads, standard EKG is the 12 leads. So first we are going to discuss the chest leads. So there are 6 chest leads, and these chest leads, suppose this is your heart, suppose this is my heart being placed, and this is your heart being placed. Okay, this is your heart being placed. Okay, and this will be my leads. So this will be, suppose, my interventricular septum. This is my interventricular septum. So I start putting these leads here. This will be my first chest lead, that's called V1, V2. V1, V2 is actually there, and this is where I insert the V1, V2 leads. So if I get ST elevations in the V1 and the V2 leads, it tells me what part of the what part of the ventricle is actually affected. That will be called anteroseptal part will be affected, because these leads are placed within the septum. They are placed anteriorly within the septum. If you look at the picture, this is called interventricular septum, and they are placed where? They are placed in the anterior portion of the septum. So if you get ST elevation in the V1, V2, it is called anteroseptal MI. It is called what? Anteroseptal MI. Anteroseptal MI is there. And do you know what artery supplied the anterior part of interventricular septum? Can anybody tell me? So if I get anteroseptal MI, what artery is blocked? Anybody knows the answer? We discussed the blood supply of the heart already.
LAD.
Left anterior descending artery. So if you get ST elevation in the V1, V2, it means left anterior descending artery. Now from this area, you're moving downward. You're moving downward. So when you go to this location, you see you're going to insert another leads that's called V3, V4. So V3, V4 are going little bit downward. So you're going little bit downward in the V3, V4. So if you get ST elevations in the V3, V4, what's the direction? What's the direction of the V3, V4? It's being directed towards the downward portion of the lower portion of the left ventricle. So this is your lower portion of the left ventricle. And lower portion of left ventricle is also called the apex of the ventricle. Is it? Apex of the ventricle. So can I say, if I get the ST elevation in the V3, V4, it indicates what? It indicates my anteroapical MI. Anteroapical. Because it is anteriorly, so it will be called anteroapical. Anteroapical MI. So anteroapical MI is what? You get the apex of the left ventricle will be affected. Anteroapical MIs. Okay. So that will be called your anteroapical MI. And can anybody tell me what artery supply the apex of the left ventricle? So if you get
LAD.
that,
LAD.
that will be proximal LAD or distal LAD?
And distal
Distal.
LED.
Distal LAD, very good. So you get V3, V4 elevation, distal LAD is actually there. Okay, distal LAD is gone. Now from V3, V4, I'm actually moving in this direction. So I put the leads here in V5, and the V6 will be inserted on the sides of the left ventricle. So it means on the side, this is called lateral wall of left ventricle, lateral wall. So if I get ST elevation in the V5, V6, it means what? What wall of the left ventricle is affected? It's called lateral wall. So you get lateral wall MI. So you get anterolateral MI or lateral wall MI. And if you get lateral wall MI, it means what artery is affected? It will be called your LCX, left circumflex artery.
So apart from LCX, OMA also, like obtuse national artery also
Excellent,
can cause.
excellent. Very good, very good. Excellent. Good job, Rahul. Very good. So your LCX artery can also, your obtuse marginal can be also blocked, and these obtuse marginal are the branches of LCX, plus they are also the branches of your left anterior descending artery. Okay, so it's not clear. It's not clear when you get the V5, V6 elevation. You will get either it is due to LCX artery or left anterior descending artery. Yes. All right. So that's actually your lateral wall MI being there. All right, so these are the 6 chest leads which cover your anterior wall of the left ventricle and the lateral wall of the left ventricle. Now you guys must be thinking, why don't we cover the posterior wall of the left ventricle? Anybody knows the answer? What's the reason? Why don't we cover the posterior wall of the left ventricle?
There is a specific leads for them.
Yeah, there's a specific lead, but standard ECG is actually 6 chest leads. But you can also go posteriorly. If you want to go posteriorly, you have to first cover the lateral wall, and after lateral wall, you will enter into the posterior wall. So if you want to enter into the posterior wall, you have to extend your leads. You have to increase the number of the leads. So you have to go from V5 to V6 to V7 to V9. And these V6 and the V7 and the V9, they will be placed on the posterior wall. Behind the scapulae, you will put these chest leads, V7, V9, and they actually indicates posterior wall of the left ventricle. So if you get ST elevations in V6, V7, V9, it means posterior wall of the left ventricle affected. So can anybody tell me what artery supply the posterior wall of the left ventricle?
Posterior descending artery.
Very good. PDA. Excellent, Archana. Very good. PDA. Excellent. So if you get ST elevations in these leads, it's due to the blockage of the PDA. Okay, so these were your chest leads. Now we are going to discuss the limb leads. Limb leads are very simple. Limb leads. So we have the limb leads, means we have the upper limb leads and the lower limb leads. So we also have the 6 limb leads. 6 limb leads are there. So we have the lead 1 and AVL. You see AVL, L for AVL, L for the left arm. So these 2 leads are placed in the left arm. Why do we place these leads on the left arm? Because the heart is on the left side. So if you look at your left arm, left arm is directed towards what wall of the left ventricle? It's directed towards the anterior wall of left ventricle, lateral wall of left ventricle, or posterior wall? Left arm.
Later.
Excellent.
Later.
Lateral.
Lateral wall. So if you get ST elevations in the leads one in the AVL, it means your lateral wall is affected, so LCX will be affected. Okay, so these are the left arm leads. And we also have the one lead which is called right arm, right upper extremity lead, that is called AVR. And we are not interested in the AVR. Why? Because my heart is on the left side. It's not on the right side. My heart is on the left side. So AVR is useless. It's AVR. There's no importance of the AVR leads. Okay, it's just being placed for the balance purpose. For the balance purpose, it's being placed. Otherwise, we are not interested in the AVR. Okay, AVR is for the right arm. Right arm. Now we have the lower limb leads. They are very important to know. Lower limbs. Lower limbs. So lower limb leads are 3 leads being placed in the lower limbs. They are called lead 1, 3, and ABF. So if you get ST elevation in these leads, you guys know that lower limb is, what's the direction of lower limbs? Lower limbs are directed where? Lower limbs are indicating what wall of the left ventricle? Anyone? Lower limb.
Inferior,
Very good.
inferior.
Very good. They are the inferior part of the body. So it means they will direct the inferior wall of the left ventricle. Inferior wall of the left ventricle is actually there. So when you get ST elevation in these leads, it means inferior wall MI is there. Inferior wall MI. And that inferior wall MI, that's called inferior wall MI. And that inferior wall MI is actually there. And what arteries supply the inferior wall of left ventricle? Anyone?
RCA.
Right, right coronary artery.
Excellent. Right coronary. Very, very important to know this artery, right? Coronary artery. So RCA, if you get ST elevation in leads leads 3, 2, and ABF. ABF is for foot. F for foot, F for the ABF. It's actually right coronary artery being involved. So these were the simple EKG leads. Now we are going to jump into the tachycardias. Okay. So tachycardias,
Sir,
Yes, what did you want to say?
sir, so I wanted to ask one question over there. Like in inferior wall MI, there's a hypotension, but in LED, if there's lateral wall MI or anterior wall MI, there's no hypotension. Why there's a hypotension in inferior wall MI?
Yeah, in the inferior wall MI, you get why you get the hypotension? Because in inferior wall MI, You get what artery is affected? Right coronary artery. And right coronary artery also supply your SA node and the AV node. So you get what? Bradycardia. And once you get bradycardia, you are going to get what? Hypotension. That's the
Yes,
reason.
sir. Yes. Thanks, sir.
Okay. So now we discuss the tachycardias, and tachycardias means increased heart rate. Tachycardia means your heart rate of greater than 100 is called tachycardia. Okay. So tachycardia is further classified into two types depending upon the current generation. What is the location of the current generation? It's being divided into the two types. Okay. If your current is actually generated above the AV node, any tachycardia which originate above the AV node, it will be called what? It will be called supraventricular tachycardia. Is it? Because it is above the ventricles. It's above the ventricle, the current generation. So any tachycardia which originate above the AV node or at the AV node, that will be called supraventricular tachycardia because AV node is sitting above the ventricles. Supra means above the ventricles. Okay, that will be called supraventricular tachycardia. Now, any tachycardia which originate below the AV node, so this will be supraventricular will be above the left ventricle, above your AV node, above the AV node or within the AV node. Now, any tachycardia which originate below the AV node, that will be called ventricular tachycardia, because below the AV node I only have what? Ventricles are sitting. So that will be called my ventricular tachycardia. That will be below the AV node. Okay, below the AV node. So that will be my, okay. So that will be the two types on the basis of the side of the current generation. But what if on the basis of the EKG finding? On the basis of EKG finding, we have the two types of the tachycardia. One is called narrow complex. Narrow complex tachycardia means your QRS complex is very narrow. So normally, normal duration of QRS complex is what? Normal duration of QRS complex is actually 100 to 120 milliseconds. Okay, so if you get QRS complex less than 120 milliseconds, it means it will narrow means it will take less time. QRS complex will take less time to happen. Okay, so QRS complex is actually narrow one, so that will be less than 120 milliseconds. So that is called narrow complex tachycardia, and narrow complex tachycardia is also called supraventricular tachycardia. Any tachycardia which originate above the AV node or within the AV node, it will always lead to narrow complex QRS complex or narrow complex tachycardia. Can anybody tell me the reason? What's the reason? What's the reason why supraventricular tachycardias are narrow complex QRS? Yep.
Because current generate very fast in a
Excellent.
atria.
Very good, Route. Current generate. So, as I discussed with you, pacemaker rate. First is SA node, then we have the AV node, then we have the atria, then we have the ventricles. So current generation rate is so faster above the AV node or within the AV node. So that is why you get the narrow complex tachycardia. So what are the examples of narrow complex tachycardias? The current can be generated in the atrias or within the AV node. I told you, if the current is generated within the atrias, that are called atrial fibrillation or atrial flutter, which we are going to discuss. And if your current is generated within the AV node, that will be called your paroxysmal supraventricular tachycardia. We are also going to discuss that. Okay, so these are the examples of narrow complex. Now, wide complex, wide QRS. Wide QRS complex tachycardias will be what? Any tachycardia which originate below the AV node. That will be called ventricular tachycardia. They are called wide one. And here your QRS complex is so wider. And if it is so wider, it will take more time. Is it? So the timing will be greater than 120 milliseconds. Okay, so these timings will be greater than 120 milliseconds. So now I will love to discuss the first narrow complex tachycardias, then I will discuss the wider complex or broader complex tachycardias. So let's discuss the narrow complex, which are also called SVTs, supraventricular tachycardias. They're also called your narrow one. So first narrow one, which we are going to discuss, is called your atrial fibrillation. Atrial fibrillation. Atrial fibrillation. So atrial fibrillation is defined as what? What's the definition of atrial fibrillation? Then we'll discuss the risk factor, causes, and symptoms of the patient. So atrial fibrillation is defined as irregular rate in the rhythm with no proper P wave. There will be no proper P wave in between the QRS complexes. So you get what? Irregularly, irregular, irregular rate and the rhythm, everything will be irregular, okay? Because RR intervals, if you look at the RR intervals, they will be not uniform. Some RR intervals will be very close to each other, other RR intervals will be, away from each other. Irregular rate and the rhythm with no proper P wave. No proper P wave. Proper P wave. Because your atrias become crazy. The atrias are generating the current in the quick succession. So that's called the atrial fibrillation. Now, what is the location of current generation? In atrial fibrillation, you can get the current generation from multiple areas of the atria. That could be multifocal. But most common side of current generation, location of current generation is very near to the opening of the pulmonary vein. And this location you should know because treatment depends upon electrical ablation. We have to do the electrical ablation of this area for the treatment. So most common side of current generation or automatic current generation foci is near the pulmonary vein. Near the pulmonary vein. Okay, near the pulmonary vein opening. So area where the pulmonary vein normally opens, that's the location of the current generation and the atrial fibrillation. So can anybody tell me the most important risk factor or trigger for atrial fibrillation? What is the most important trigger which will lead to atrial fibrillation? So if you remember this trigger, the causes are the cup of tea for you guys. So what is the most important trigger for AFib? Remember, for the atrial fibrillation, the important trigger is called left atrial dilation. Any factor or any cause which causes left atrial dilation will lead to your atrial fibrillation. So left atrial dilations. Now you guys will tell me what are the causes of left atrial dilation. So any pathology which cause left atrial dilation will lead to your atrial fibrillation. So one cause I see here in the chat box is called your mitral stenosis. Very good. Mitral stenosis. What other pathologies can cause the left atrial dilation? Yes, that's very important to understand.
Hypertension.
Excellent, Archana. Very good. Could you tell me how hypertension causes left atrial dilation? What's the mechanism?
Because in the hypertension, left ventricular stiffening is there.
Very
Because
good. Very good. Left ventricular hypertrophy will happen. And in the left ventricle, you will get what hypertrophic cardiomyopathy. Is it? Hypertrophic cardiomyopathy. So left ventricular hypertrophy means you reduce left ventricular cavity. Is it?
yes.
And when you reduce the left ventricular cavity, you put more pressure in the left atrium. The blood is going to stay within the left atrium. So you get what left atrial dilation. Hypertension is the number one risk factor for the AFib we see in the practice. Okay. Is the number one risk factor we see in the practice. So hypertension, very good. What other cause can cause the left atrial dilation? Very good. Any disease which causes the left atrial dilation will lead to the AFib. That is a takeaway point from here. Make your life very simple. Can I say like this? Renal failure patient. Renal failure. So when I get renal failure, what will happen to my blood volume? My blood volume will increase or decrease?
Increased.
Excellent. Your blood volume will increase because you cannot remove the urine out of the body. So blood volume will increase. And I have seen a lot of the patients who have the renal failure and they get the AFib because of volume overload state. And once after dialysis, their AFib is no longer present because I remove the trigger. And I remove the volume out of the body and their AFib will be treated. So renal failure patient, they are admitted to the CVICU or they are admitted to the cardiac floor with a history of AFib. And once we do their dialysis, their AFib is actually treated. So renal failure patients can get the increased volume overload state. Okay, so renal failure is actually there. What other disease can lead to your AFib? Could be coronary artery disease. When you get coronary artery disease, it will lead to scar tissue production within the left ventricle. And when you get scar tissue production in the left ventricle, it will lead to what? Stasis of the blood. Is it? And why don't you say the MI? After MI, you can get the atrial fibrillation. And how does you get it? Because of stasis of the blood. And when you get stasis of the blood, that will increase the pressure in the left atrium. So when you increase the pressure in the left atrium, you're going to get left atrial dilation. And can anybody tell me holiday night syndrome? What is holiday night syndrome? So patient is having holiday night syndrome and
Lot of alcohol can cause.
excellent, very good, Rahul. So on weekends, the patient will drink a lot of the alcohol, and alcohol can actually lead to AFib, acute AFib. Simply, I will say acute AFib. So they drink a lot of the alcohol, and alcohol is a trigger for the AFib. So these were the causes of AFib. Now, what will be the presentation or symptoms of the patient? The symptoms of the patient for AFib will be what? Patient will have the palpitation, patient will have the dizziness, might be syncope could be there, or shortness of the breath. So these will be the symptoms of the patient. Now, what are the complications of AFib? Can anybody tell me the number one complication for AFib?
Clot formation,
Very good. It's clot formation. Why?
Yes.
What's the reason?
because the blood becomes stasis and it's more turbulence.
Very good. Where the blood is staying? In the left ventricle or left atrium?
Left atria.
Left atrium.
Left atrium. Very good. The blood is staying within the left atrium. So you might get what? Clot formation or thrombus formation. And that thrombus formation might lead to stroke of the patient. Okay, that leads to stroke. Okay, and you can get the stroke being in the patients. All right, so stroke can be seen in these patients because of the. Okay, now how do we treat it? Treatment of the AFib. Yep.
Blood thinner.
No, before blood thinner, you have to be very careful about the rate and the rhythm. Is it? Why you are actually
Yes.
first you will treat the condition or you will treat the complications?
So first we need to
Rate
decrease
control.
the
Rate and the rhythm control. Rate control. So what medications will I give to control the rate? You
like
see,
beta blocker.
very good. How beta blocker will control the rate? Can anybody tell me? Beta blocker, what's the mechanism here?
So it will block the B1 receptor of the heart, so the work would be
No,
done.
I'm not getting. You see, the current generation side is not SA node. It's near the pulmonary vein. It's near the pulmonary vein. Huzi is close, but not close enough.
to-
You see,
Decrease myocardial contractility.
no. You see,
Cardioversion.
no, I'm asking how beta blocker control the rate. So you see, beta blockers will do what? You see, current generation, what's the location of current generation? Near the pulmonary vein opening. And that current passes through the AV node. From AV node, it will pass to the left ventricle. Is it? So I have to slow down the AV node. I have to slow down the conduction rate of AV node. When I give the beta blocker, it will do what? It will increase AV nodal delay time. Is it? Increase AV nodal delay time, which I need in the AFib, because in the AFib, I'm worried about my left ventricle. I'm not worried about the left atrium. I'm more worried about your left ventricle. Or rate is what? What is heart rate? It is related with the left ventricular activity. So I will actually increase AV nodal delay time. Okay, so that will actually send less signals to, or less action potentials will be going to my left ventricle. So beta blockers, and if patient does not have the control in the heart rate with the beta blocker, we will add another rate control medication that will be called calcium channel blockers. So calcium channel blockers like verapamil and deltaism, these should be
Deltaism.
cardioselective. These should be cardioselective, and they have the same mechanism. They will increase AV nodal delay time. Okay, so you do deltaism and the verapamil for the calcium channel. So rate control is there. And I did a rate control, but patient is still not feeling good. So what will you do? You will do the rhythm control. So can anybody tell me what's the first line rhythm control medication for the
Amiodaron.
Excellent.
Amiodarone.
Very good. Amiodarone is actually there. So you have to do the amiodarone. And still patient is not feeling well. I did the rate control medication, rhythm control. What will be my next best step?
Cardioversion.
Excellent. Excellent. Very good. Cardioversion.
Cardioversion.
After cardioversion, what will you do? A patient is not still feeling well. What you have to do? You have to do the definitive therapy that's called electrical ablation. So you have to enter into the left atrium, electrical ablation. And tomorrow I will ask you guys a question: how will you enter into the left atrium? Electrical ablation.
Sir, just now a patient came in the emergency. He has got the electrical ablation surgery done, and he was just in the he was walking. He was feeling dizziness, and just he came. Then I sent him to the higher center for that.
He had electrical ablation done.
Done, yes, sir. For
And
5 days back.
okay, and now he's feeling what?
Yeah, the same, the dizziness and all. Then I got the ECG done. It was almost okay. Still, I sent him to the higher center.
Yeah, you did a good job. You send him, say that's good. You have to send them to the cardiac unit.
Yes,
Might
sir.
be, yeah, that might be the complication. Yes, very good. Okay, so that will be your, all right. So electrical ablation is there, and for the treatment, you have to do the blood thinners now, heparin, or you have to put on the anticoagulants for the patient. So that's about AFib, and tomorrow we discuss more multifocal. I'm getting a little bit late. Okay, so tomorrow I'm not sure I'm available or not. I will actually confirm in the group. Okay. All right, so okay, thank you for coming, and I'm sorry for any inconvenience. My internet actually disturbed me. So you guys will receive the 2 recordings, okay, today. All right, thank you so much for coming. Bye bye, take care.